All right, welcome to the deep dive. Today, we're going to be, talking about something I think everyone listening has probably experienced at some point. Local anesthesia at the dentist. You know that feeling of getting your mouth numbed, the whole freezing thing. We're going to break down exactly how dentists choose which numbing technique to use, all those different injections they give, what's the rationale behind it all.
Yeah, it's kind of like demystifying the toolkit, right? We've
Right.
got a ton of info here that really dives deep into how these choices depend on the anatomy of your mouth, particularly the differences between your upper and lower jaw.
Makes sense. So, we all know our upper jaw is called the maxilla and the lower one's the mandible, but how does that actually impact the choice of anesthetic technique?
Well, it all comes down to the nerves and the bone structure. The goal is always to be as minimally invasive as possible, using the smallest amount of anesthetic, and target it precisely to block pain signals effectively.
Hmm.
Getting you numb exactly where you need to be, nothing more, nothing less.
Efficiency and comfort, two things we all appreciate in the dental chair. Okay, so, big picture. What are the main ways dentists achieve this freezing effect?
We can break it down into three main types of injections. First, you've got local infiltration. This is basically flooding the area right around the treatment site with anesthetic, directly targeting the small nerve endings there. Think about getting your gums numbed between two teeth, like before a deep cleaning. That's often local infiltration.
Okay, very direct. What's next?
Then there's the field block. This is where the anesthetic is placed a bit further away from the treatment site, but near a larger nerve branch, to numb a wider area. So the target's a bit bigger, and the effect setteds a bit further.
So, like a bigger net, capturing more nerves in one go. And the third type.
That's the nerve block. This involves injecting anesthetic near a major nerve trunk, often quite a distance from where the actual work is being done. The idea is to block pain signals much earlier in their journey to the brain. You've probably heard of things like the inferior alveolar nerve block or the posterior superior alveolar block. Those are classic examples of nerve blocks.
Right, so blocking the main highway of pain signals. Now, I'm guessing some of these techniques are more suited for the upper jaw and some for the lower jaw.
You're absolutely right. Some techniques are definitely more commonly used in one over the other. It really depends on the anatomy and how readily the anesthetic spreads through the bone. For example, the upper jaw is generally less dense than the lower jaw, so techniques like the supraperiosteal injection, often called an infiltration, work really well there.
Okay, so upper jaw first. You mentioned the supraperiosteal injection. Let's break that one down.
Sure. This technique targets the larger nerve endings near the tooth's root, just above the bone, hence the name supraperiosteal. Because the bone in the maxilla is relatively thin, the anesthetic diffuses pretty easily, reaching the smaller nerve endings and numbing the pulp of the tooth, as well as the surrounding gums and tissues.
So, very localized numbing for a specific tooth or a couple of teeth.
Exactly. It's the go-to choice for most single-tooth procedures in the upper jaw. It's got a really high success rate, usually well over 95%, and it's generally pretty easy for the dentist to do and quite comfortable with the patient.
Sounds like a winner. But I'm guessing there are times when it's not the best option.
Of course, if you're working on a larger area involving multiple teeth, doing multiple supraperiosteal injections might require a lot of anesthetic overall, which might not be ideal. Also, if there's an infection right at the injection site, you wouldn't want to risk spreading it. And sometimes the bone over the tooth root can be a bit denser, making the anesthetic less effective.
So, in those cases, what are the alternatives?
Well, there are other techniques like the periodontal ligament injection, where you inject right into the ligament around the tooth, or an intraosseous injection, which goes directly into the bone. And then there are the regional nerve blocks, which can numb a whole section of the jaw.
Okay, that makes sense. Let's talk about those regional blocks, starting with the posterior superior alveolar, PSA, nerve block. What is that one typically used for?
The PSA, sometimes called a tuberosity block, is great for numbing the molars in the upper jaw, usually the third, second, and first molars. Studies show it's effective in about 77% to 100% of cases for those teeth.
So it's pretty reliable for the molars.
Yeah, mostly. There's one little caveat, though. Sometimes the very front root on the cheek side of the first molar, that mesial-buccal root, doesn't always get numb with just the PSA. That happens in about, 28% of people. So dentists always have to be mindful of that.
Interesting. So it covers most of the back teeth in the upper jaw. What else does it numb besides the tooth itself?
It also gets the gum tissue and the bone on the cheek side of those molars.
And when would a dentist choose a PSA over a supraperiosteal injection?
There are a few reasons. First, if you're doing work on two or more upper molars, the PSA just makes sense. Fewer injections, less anesthetic overall. Also, if there's an infection or inflammation right where you do a supraperiosteel, a PSA is a safer bet. And sometimes that supraperiosteel just doesn't take as well, maybe because of denser bone, so you'd switch to the PSA.
Okay, so it's more efficient and sometimes necessary for a good numb feeling. Any downsides to the PSA?
There's one thing to be aware of, the risk of a hematoma. That's basically a bruise, a collection of blood under the skin.
Oh.
Because there's a network of blood vessels back in that area, you have to be really careful with the needle. That's why we always use a shorter needle for PSAs and inject very slowly, always aspirating to make sure we haven't hit a vessel.
I bet a hematoma can be quite uncomfortable.
It can be, yeah. It's not dangerous, but it can cause some swelling and bruising that takes a few days to go away.
Got it. So moving on to the front of the upper jaw, we have the infraorbital nerve block, also called the ASA block, right?
Yep, the anterior superior alveolar block. That one's really good for numbing, a whole chunk of the upper front teeth, usually through the central incisor all the way back to the premolars, and even part of the first molar. It's effective in about 72% of cases.
So a good option for when you need to work on several teeth in the front?
Exactly. Plus, it uses way less anesthetic than doing individual supraperiosteals for each tooth. Think 0.9 to 1.2 milliliters versus potentially 3 milliliters.
Wow, that's a significant difference. Aside from the teeth themselves, what else does it numb?
It gets the gum tissue and bone on the cheek side of those teeth, but it also numbs the lower eyelid, the side of the nose, and the upper lip, all on the same side as the injection.
Wow, quite a wide area of effect. So when is the infraorbital block the go-to choice?
It's great for procedures involving more than 2 teeth in that front section, especially when you also need to numb the cheek side tissues. Also, if there's an infection or inflammation where you'd normally do a supraperiosteal, the infraorbital block is a good alternative.
Any downsides to this technique?
Well, sometimes finding the exact spot for the injection can be a little tricky just because of the anatomy in that area. And, some dentists might be a little apprehensive at first because of the proximity to the eye, but with proper technique, it's really safe.
So basically, experience and precision are key for that one. Now, what about the palate, the roof of your mouth? The greater palatine nerve block comes into play there, right?
Exactly. That one's all about numbing the palate, specifically the area behind the canine tooth. What's great is you can get really good numbness back there with just a tiny bit of anesthetic, usually less than half a cartridge.
And what does that numbness cover specifically?
So you're looking at the posterior hard palate, meaning the bony part, and the soft tissues covering it, all the way up to around the first premolar and toward the middle of the palate.
Sounds like a good option for when you need to work on the back part of the palate.
Yep. Especially if it involves multiple teeth or when you need to do some work below the gum line on that side.
Okay, so what are the pros and cons of this one?
The main advantage is it really minimizes how many times you need to poke the palate with a needle. Less discomfort, less anesthetic overall. The downside is it doesn't do much for controlling bleeding, so if that's a concern, you might need to do some extra local infiltration with a vasoconstrictor.
That makes sense. Now, what about the nasopalatine nerve block? I've heard that one can be a bit rough.
Yeah, the nasopalatine can be a bit,
Intense.
Yeah. It's really effective for numbing the front part of the palate, but the injection itself can be a little uncomfortable. The upside is you can get a wide area of numbness with a really small amount of anesthetic, like a quarter of a cartridge.
So a trade-off, maybe more discomfort up front, but less poking overall and less anesthetic.
Exactly. It's all about weighing the options.
Yeah.
Right?
So when would a dentist choose this block knowing it might not be the most pleasant experience?
It's mainly for when you need to work on more than 2 teeth in the front part of the palate, or when you need good numbness for periodontal work or even minor oral surgery in that area.
Got it. So if a dentist really wants to avoid the nasopalatine block, what are the alternatives?
Honestly, the main alternative is just doing multiple local infiltrations right on the palate, wherever you need numbness. It might be a little more poking, but it could be less intense overall.
Okay, that's good to know. Now, you also mentioned local infiltration of the palate as a separate technique. How is that different from the nasopalatine or greater palatine blocks?
It's much more localized. Think of it as pinpoint numbing, right at the spot where you give the injection. It's really for very specific things like placing a rubber dam clamp or doing a small filling on 1 or 2 teeth where you need some palatal numbness.
So very small area, very specific purpose.
Yeah, it's not for major pain control. It's more for managing discomfort from very specific things.
Okay, makes sense. And then we have the big one, the maxillary nerve block. This one sounds like it numbs a whole half of the upper jaw.
Yep, that's exactly what it does. It targets the maxillary nerve, that's the main nerve supplying sensation to the whole upper jaw, and effectively numbs an entire quadrant. There are a couple of ways to do it, either through the greater palatine canal or the high tuberosity approach.
Are those two approaches significantly different?
They are, yeah. The greater palatine canal approach is a bit more technically demanding, but it's usually less traumatic for the patient. The high tuberosity approach is a bit simpler, but it carries a slightly higher risk of that hematoma we talked about.
Okay, so pros and cons to each. So regardless of how it's done, what exactly gets numb with a maxillary nerve block?
Everything on that side of the upper jaw, all the teeth, the gums, the palate, even parts of the cheek and lower eyelid, it's a really profound block.
Wow, that's a lot of numbness. When would you actually need something that extensive?
Think major oral surgery, extensive periodontal work, or multiple procedures all happening in the same quadrant.
Hmm.
It's also an option if you have an infection or inflammation that prevents you from doing any of the other blocks.
Makes sense. Now, let's get into the pluses and minuses of each approach. Starting with the high tuberosity, what are the advantages there?
Well, with the high tuberosity, the main advantage is it's pretty straightforward and very effective. It also minimizes the number of injections needed for a full quadrant anesthesia, which is great for the patient. The success rate's really high, too, over 95%.
Okay, but you did mention a higher risk of hematoma. What else is there to be cautious about?
Right, the hematoma risk is something to keep in mind. It's also worth noting that the high tuberosity approach doesn't rely on a very specific bony landmark, so you have to be extra careful with needle placement to avoid overinsertion.
So precision and experience are key. And what about the greater palatine canal approach?
That one's generally considered less traumatic, but it's a bit more challenging technically. And it doesn't offer much in the way of controlling bleeding, so you might need to do additional infiltrations for that.
Interesting. So are there any situations where you wouldn't do a maxillary nerve block at all?
Definitely. You wouldn't do it if the dentist isn't really comfortable with the technique or with really young kids who might move a lot. And if there's an infection or inflammation right at the injection site, that's a no-go as well.
What about specific contraindications for each approach?
Well, for the greater palatine canal
Yeah.
approach, you wouldn't use it if you can't locate the canal or if there's any kind of bony obstruction, which can happen sometimes.
Okay, and if a maxillary nerve block isn't possible, how do you achieve that full quadrant anesthesia?
Basically, you'd have to do all the individual blocks, the PSA, the ASA, the greater palatine, and the nasopalatine all together. So you can see why the maxillary nerve block is such a valuable tool when it's appropriate.
It definitely simplifies things. Now, any other complications to be aware of aside from hematoma?
With the greater palatine canal approach, there's a small risk of, going too deep with the needle and actually penetrating the eye socket. That's a very serious complication, and that's why the technique has to be absolutely perfect.
Okay, that's scary.
It is. It's very rare, but it's something we're always aware of. And with that same approach, there's also a chance of hitting the nasal cavity if the needle goes too far inward. You'd know right away because you'd see air bubbles in the anesthetic syringe, and the patient might feel the anesthetic dripping down their throat.
So vigilance and precision are definitely crucial with all of these techniques. It seems like getting the upper jaw numb is generally pretty straightforward though, right?
In most cases, yeah. The bone structure in the maxilla is such that the anesthetic spreads pretty readily, which is why a lot of dentists just rely on supraperiosteal injections for most upper jaw work. The regional blocks, like the PSA and ASA, are really reserved for those specific situations where a supraperiosteal isn't enough. And the palatal injections, while maybe not the most pleasant, are generally manageable with good technique.
Okay, that makes sense. Now let's shift gears and talk about the lower jaw, the mandible. I've heard that getting reliable numbness there can be a bit more challenging.
Yeah, the mandible's a bit trickier, for sure. The bone is much denser, and the main nerve that supplies the teeth, the inferior alveolar nerve, is situated in a way that makes it harder to reach reliably. The success rate for the inferior alveolar nerve block, the IANB, which is the standard block for the lower jaw, is only about 80% to 85%.
So that means almost 20% of the time it doesn't work perfectly on the first try.
Pretty much, yeah. And because the bone's so dense, we really have to be super precise with where we place the anesthetic, ideally within a millimeter of the nerve.
Okay, let's break down the IAMB then. What exactly does it numb?
So it targets the inferior alveolar nerve, which then branches out into the incisive and mental nerves. It usually numbs all the teeth on that side of the lower jaw, the lower part of the jawbone itself, the gum tissue on the cheek side from the premolars forward. And because the lingual nerve's usually affected too, it numbs the front 2/3 of the tongue and the floor of the mouth.
Wow, that's a lot of territory.
It is, yeah. And that's why it's the go-to choice for most quadrant dentistry in the lower jaw. One injection, and theoretically, you've got a whole side numb.
Sounds efficient, but I'm guessing there are some downsides too.
Definitely. If you only need to work on a couple of teeth, that tongue and lip numbness is pretty overkill and can be uncomfortable for the patient. And as we talk about, the success rate isn't perfect, and there's more anatomical variation in the mandible, which can make things unpredictable. And then there's the whole positive aspiration thing, meaning there's a higher chance of hitting a blood vessel with a needle.
Okay, so it's not foolproof. And you mentioned anatomical variations. What does that mean, practically speaking?
Sometimes the inferior alveolar nerve actually splits into two branches. When that happens, a standard IAMB might only numb part of the jaw. That's why we have other techniques like the Gao gates, which are more likely to catch both branches.
So a backup plan for those tricky cases. Now let's go through those alternatives to the IAMB, starting with the buccal nerve block. This one sounds pretty specific.
The buccal nerve block is very specific. It only numbs the cheek-side gum tissue right next to the lower molars. That's it.
Okay, so when is it used?
Basically, anytime you're doing work on those tissues, like deep cleaning, placing a rubber dam clamp, or working below the gum line on the cheek side of those molars.
Very targeted. Any downsides?
Not really. Sometimes you might get a little zap of pain if the needle hits the periosteum, but it's very brief. And of course, you wouldn't do it if there's an infection in that area.
Makes sense. Now, what about the Gao gates technique? You mentioned it's a true mandibular nerve block. What does that mean?
It means it blocks a much larger portion of the mandibular nerve right as it exits the skull. The Gao gates gets the inferior alveolar nerve, the lingual, the mylohyoid, mental, incisive, auriculotemporal, and even the buccal nerve in about 75% of cases.
So it's like a super IANB, hitting more nerves in one shot. What are the advantages of that?
Well, first of all, it's got a much higher success rate, like over 95% once you get the technique down. And it's less likely to have a positive aspiration.
So less chance of hitting a blood vessel.
Exactly. And it's also more reliable when you have those anatomical variations with the inferior alveolar nerve splitting. It catches both branches more consistently.
Okay, so it's more comprehensive and more reliable. What are the downsides?
The downsides are pretty similar to the IANB, really. You get that tongue and lip numbness. And sometimes it can take a bit longer for the numbness to kick in.
Okay, so the Vazirani-Akinosi technique, that one's the closed mouth approach, right? What's the deal with that?
Yeah, the Vazirani-Akinosi or Akinosi block is your go-to when someone can't open their mouth wide enough for a regular IANB or a Gao gates.
So like if they have trismus or something.
Exactly. It's a really valuable technique in those cases.
What does it actually numb?
It gets all the same nerves as the IAMB, pretty much the inferior alveolar, mental, incisive, lingual, and mylohyoid. So you get numbness in all the teeth on that side, the jawbone, the cheek, the tongue, the floor of the mouth, the works.
Okay, so same numbness, but different approach.
Right.
What are the pros and cons of doing it this way?
The biggest advantage is that it works even if you have limited mouth opening. And it tends to be less traumatic for the patient. Less post-op discomfort, too. Less trismus.
Okay, so gentler, basically.
Yeah, you could say that. The downside is it's a little more technically demanding because you don't have visual confirmation of where the needle is going.
Makes sense. Now, are there situations where you wouldn't use the Vazirani-Akinosi?
The same general contraindications as the other blocks, really active infection at the injection site, patients who might bite their tongue or lip because of the numbness, and you have to be able to feel the landmarks on the inside of the jaw to do the block correctly.
Got it. Now, onto the mental nerve block. This sounds like another localized one.
The mental nerve block is very localized. It basically numbs the gum tissue and the skin on the chin, all in front of the mental foramen, which is around the second premolar area.
Okay, very specific. When would you use that one?
It's mostly for working on the soft tissues in that area, biopsies, suturing, that kind of thing.
Any downsides?
Not really. High success rate, easy to do, pretty comfortable for the patient, just a slight risk of hematoma, as with most injections.
All right, last one on our mandibular block tour, the incisive nerve block. You mentioned this one gets confused with the mental nerve block sometimes.
It does, yeah. And it's understandable because they both target the same area, but the incisive block goes a step further. It numbs the pulp of the teeth in addition to the soft tissues.
Okay, so it's like a super-powered mental nerve block.
Kinda, yeah.
Yeah.
But importantly, it doesn't numb the tongue. That's the key difference.
So when would you opt for the incisive over the mental arm?
When you need to work on the teeth themselves, the premolars and the front teeth, but you don't want that tongue numbness. It's a great alternative to doing two IAMBs, one on each side. which can be a lot for the patient to handle.
Makes sense. Any downsides to the incisive block?
The main one is that it doesn't get the tongue, so you'd need an additional injection for that if it's necessary. And in rare cases, it might not provide complete numbness right at the midline where the nerves from both sides overlap.
Okay, that makes sense. So we've covered all the main blocks for the upper and lower jaw. Now let's move on to those supplemental techniques you mentioned earlier.
All right, that's good.
First up is the periodontal ligament PDL injection.
Ah, the PDL. This one's interesting. It involves injecting a small amount of anesthetic directly into the space between the tooth and the bone.
That sounds very precise.
It is, and it's super useful for numbing just one or two teeth without affecting the surrounding tissues too much.
So no lip or tongue numbness with this one.
Exactly. It's a great option for when you just need localized numbness or when you're working on multiple quadrants and don't want to give a bunch of IA and Bs.
Okay, when else would you use a PDL injection?
It's also handy for when other blocks don't work well or when you need to pinpoint the source of pain in a specific tooth.
So it's versatile. Any downsides?
Well, getting the needle in that tiny space can be a bit tricky sometimes, and some people find the injection itself a bit uncomfortable. And there's always a small risk of causing some irritation or damage to the tissues if you're not careful.
Sounds like a delicate procedure.
It is. It's all about finesse.
Okay, next up is the intraseptal injection. That sounds like it goes right into the bone.
That's right. It goes into the bone between the teeth.
When would you ever choose to do that?
Well, it's another way to get very localized numbness without affecting the lip or tongue. It's great for single tooth procedures or when you're working on a few teeth in a row.
Okay, so similar benefits to the PDL in terms of targeted numbness.
Exactly.
Any downsides to the intraseptal?
Sometimes you need a special syringe for it, and it can cause some heart palpitations, especially if you use anesthetic with epinephrine.
Oh, that's not ideal.
No, not really. We usually use plain anesthetic for intraseptals to avoid that.
Okay, good to know. Last but not least, the intrapulpal injection. That name doesn't sound very pleasant.
It's not the most comfortable, no, but it's effective.
What's it for?
It's basically a last resort when you can't get a tooth numb any other way. You inject the anesthetic directly into the pulp chamber of the tooth. That's where the nerve lives.
So, like, straight into the nerve?
Oh,
ouch.
it can be a bit intense, yeah, but it works.
Why wouldn't you just do that all the time then if it's so effective?
Because it's pretty traumatic, honestly.
Yeah.
And you have to have already opened up the tooth to access the pulp chamber.
Right. So it's like a last resort when nothing else works.
Exactly.
Well, this has been incredibly informative. It's amazing how much goes into something as seemingly simple as getting numb at the dentist.
I know, right? It's a whole science.
So, to sum it all up, the choice of anesthetic technique really depends on what needs to be numb, the anatomy of the individual patient, and any other factors that might influence those choices.
Exactly. The goal is always to maximize comfort and minimize any risks.
It really makes you appreciate the skill and knowledge that dentists bring to every procedure. So as we wrap things up, here's a final thought for everyone listening. Think about all the factors that go into choosing the best anesthetic approach, how well it numbs the area, the potential risks or complications, and the overall patient experience. What do you think are the absolute most important things for a dentist to consider when making that decision? Food for thought. Thanks for joining us for another deep dive.